Hi, everybody. Dr. Jay Harness from BreastCancerAnswers.com, and also a proud advisory board member, the medical advisory board member of EmpowerHer.com. And it's my real privilege today to welcome to Southern California Dr. Philip Sarrel, who is another member of our advisory board at EmpowerHer. Phil is a retired emeritus professor of obstetrics, gynecology, and psychiatry at Yale. Phil, welcome to Southern California.
Well, thank you, Jay. It's a great pleasure to be here, especially this time of the year.
Yes.
You can't imagine the difference between here and Connecticut, where I would ordinarily be.
Absolutely.
I talked to my daughter about a half hour ago, and there's 2 feet of snow on the ground.
Phil, you and I, almost 2 years ago, did a wonderful interview that got posted at YouTube, has been seen by thousands of people, really talking about the importance of estrogen replacement in women who have had hysterectomies. And I think one of the ways we ought to start off with our audience today would be to sort of summarize some of those important points that we made a couple of years ago.
Well, that discussion was triggered by the publication of a very important paper from a study called the Women's Health Initiative.
Right.
This is our major National Institute of Health funded study that's been going on for many, many years. And the study that we discussed was one of women who had had a hysterectomy and were just given estrogen-only therapy.
Right.
Remember,
Okay.
we also talked about the difference for women with a uterus and where you have to add a second hormone to protect the uterus. But these were women where that wasn't an issue.
Right.
So what the Women's Health Initiative could do was look at, well, what happens to women if you give them estrogen only versus a placebo.
Right.
So this is the kind of trial that's needed, and it was a once in a lifetime. And the U.S. government spent $750 million on it.
Wow, holy
So
smokes.
that was unique for women's health.
What were the key points from
The key points were, number one, all of the women from age 50 to age 79 who received estrogen for a period of over 7 years showed a reduction in the risk for developing breast cancer.
Wow.
That was greater than 20%. And what's more important is it reached, because the statisticians go after these numbers and they say, well, we have to prove it's statistically significant, and it was.
Right.
That's the most important point we made. But it was also true that in that study, if women started estrogen replacement when they were under age 60, age 50 to 59 or younger, then in fact they showed a reduction in heart disease, they showed a reduction in bone fractures, they showed a reduction in mortality. And I had just published a paper that explained the difference between women after hysterectomy using estrogen versus not using it, and the fact that so many women are afraid of using the hormone.
Right.
And that's unwarranted. That's why we're talking.
But I think
to get the record straight.
Yeah, absolutely. And I think part of the confusion about all this were the reports on women who still had their uteruses in place, who were on combination hormone replacement therapy. And the culprit there was really the progesterone.
Right.
Increasing the risk of breast cancer. And then we saw a spike in breast cancer incidence almost when women stopped taking the combos, if you will. That incidence started to drift back down. And I think that's part of where all the fear comes from. Is that a fair summary?
Well, it was even more complicated than that,
Okay.
because the women who received the combination treatment didn't show any reduction in heart attacks versus the women with estrogen, who showed a major reduction in heart attacks. They didn't show the reduction in mortality that the women showed. They showed a slight increase. So it's not only that they showed an increased risk for breast cancer, they had an increase for thrombosis and embolus to their lungs. They had an increased risk for stroke. They had, you name it, it was a disaster.
Yep.
And that frightened everybody, not only the women, but the doctors as well.
Sure.
The problem was that the two studies didn't get published at the same time. When the first study was published, everyone was alarmed. Millions of women who had been using hormones stopped. And then 2 years later, when the good data came out, it wasn't heard.
Got it.
So what we did last time was to pull it all together and say, well, what's happened in these 10 or 12 years since the original publications? And what's happened is that millions of women have gone without any kind of hormone replacement out of fear. And for the women who have had a hysterectomy, it's an even greater problem. And you may remember we gave Angelina Jolie as an example because she had just published her story of being genetically predisposed to developing breast or ovarian cancer. She had had her ovaries removed, her breasts removed, and then in order to receive best care available, she was given estrogen replacement, because it is clear that in a woman her age, women, certainly women under age 50, who lose their estrogen levels, they are doomed to much greater problems. And if you replace their estrogen now, and what has come out in the 2 years since we talked, is very clear data saying if you give the woman who's had all of these procedures to prevent cancer, but you give her replacement estrogen as a young woman, she will show no increased risk for developing breast cancer, despite having the genetic predisposition.
Excellent.
That's the big point.
Oh, very good. So let's hold that thought, and we're going to elaborate on it in a few minutes. But we happen to have up here on the screen a logo of a foundation that you have created. I'm privileged to be a member of your board, albeit a minor member of your board, and what you're doing is absolutely fantastic. AHA. What in the world is AHA, Philip Sarrel?
Well, AHA stands for the Advancing Health After Hysterectomy Foundation.
Okay, AHAH. Advancing
we
Health.
own the trademark.
Yeah, I see that. Advancing Health After Hysterectomy. Very, very unique. And I believe this is the logo for the foundation.
And the logo is pointing out that when you look at a vast body of literature now, we're not talking about just a few papers here and there. We're talking about a vast body of literature. In the last year, I've been working with a national committee pulling all of this together, and our drop box, which is where all the papers get stored, has almost 250 papers in it.
Holy smokes.
I mean, it's really, well, one of the problems, of course, is there's so much to know, and so much has been published. It's overwhelming if this isn't what you know about.
And then at Empower, I think you shared with me that you actually, at empower.com, you actually have a spot for AHA that women can come to, family members can come to. Why don't you tell us a little bit about that?
Yes, so if you go to empower.com/AHA, you get to the AHA Hub. And the AHA Hub has, at that site, a series of articles written. My wife is the writer. She is a professional social worker, but for the last 35 or 40 years, she has written professionally mainly for women's magazines, for Glamour, for Red Book. For many, many years, we had our own column in Red Book magazine. So she has written these articles for the attention of women. And it's a series of different topics. We also have we have a link to the YouTubes. So we have all sorts of as up-to-date information as we can get. What we like about being able to do this is that for every article or every discussion that's up there, we have the references. We also have an independent reviewer who reviews everything we submit for accuracy, reliability. So I think it's working. And from what we've heard, women are going to that site.
Well, the thing that not only have I been impressed by you for many years, but I'm impressed by AHA, but particularly the other members of the board who you've got on the AHA board. Maybe you could just highlight who some of these are very distinguished people along with yourself.
Well, they range everywhere from the professor of gynecologic oncology at UCI, Dr. Desire, to the professor of molecular cardiology at USC, Dr. Hodis, to others around the country who are really quite renowned in the field of women's health, not only as researchers, but as deliverers of health care.
Right.
So it's a quite sophisticated group.
Yes, sir, it is. As I said, I feel like I'm just a little member of a group of highly distinguished people here.
Well,
so this is
an
great.
expert in breast cancer is extremely important
Yeah, well, thank
to
you.
be a member of this group.
Yep.
It's in the sharing of the information and knowing that this is an
Sure.
issue that is so much on women's minds.
Absolutely.
The findings that when it comes to risk benefits, you can see from our little logo that the benefits so far outweigh the risks.
Well, we've got up here on the computer some slides that you showed at another meeting, and we thought this was really a wonderful slide to have up. And why don't we explain this? Think of menopause symptoms as warning signs of diseases.
Yes.
Phil, talk about this, will you please?
And the reason why we created this canary in the coal mine, it's actually taken from a paper that was published in JAMA's Internal Medicine, in which they presented the data. Women who have untreated hot flashes, and there are millions of those women,
Sure.
need to understand that what's happening during the hot flash is affecting their arteries, is affecting their insulin production,
Right.
is affecting calcium in their bodies, that if you don't treat those hot flashes and they go on untreated, you see an increased risk for cardiovascular disease, mortality is increased, hypertension is increased. You unfortunately become a patient unnecessarily.
Right.
And that we did one study of women in the workplace going through this and finding that if we took 250,000 women with hot flashes who went to work every day for a Fortune 500 company and compared with 250,000 who didn't have them, this 250,000 in 1 year, the women with the hot flashes, age 45 to 55, these women had 1.5 million more doctor visits in 1 year.
Wow.
And their insurance costs were almost $337 million,
Wow.
all avoidable.
Okay.
So
Now,
that's the reason.
Some of my breast cancer patients or breast cancer patients that are out there in the viewing audience today are saying, wait a minute, I'm on tamoxifen as an anti-estrogen and having hot flashes, which my doctors tell me is good because it shows that tamoxifen is working. Or you have women with breast cancer who are on aromatase inhibitors, where we're not only is it an anti-estrogen, but absolutely trying to cut down the production of estrogen. They may be listening to you and thinking to themselves, oh my word, am I now going to have increased more disease because I'm on the anti-estrogen therapy versus the protective effects from my cancer? Have there been any studies that have looked at that, Phil?
Well,
that you can
that's where these last 2 years come into play.
Okay.
Because, in fact, there is really encouraging information for those women.
Okay.
If we stay with the concept of using either the aromatase inhibitor or the tamoxifen for the 5-year period, which was the original thinking,
Correct.
then the women we know by definition then will have had 5 years of a low estrogen state.
Correct.
Now we see the data that says if the women have gone through that, yes, they had to go through a difficult time. During that period of time, by the way, if they had problems with dryness and pain with intercourse, they could use vaginal estrogen even while they were on their tamoxifen or aromatase.
Right.
But I think that we all would agree when they're in that first 5-year period, that comes first.
Okay.
The inhibitor or the tamoxifen. Then we see that you're done with that when you finish that phase, Then, if women are given estrogen to follow, they indeed, compared to placebo, they indeed show a much reduced risk for recurrence.
Isn't
and in
that
fact,
fascinating?
and as a matter of fact, every single study shows that the women who received estrogen afterwards show a reduced risk of dying of breast cancer. There is no exception to what I just said.
Wow.
So we have then really important recent data that is very important for these women to know. Now, there's another group of women who would come to your attention, like the Angelina Jolie women who have a BRCA
Correct.
gene components, or who have, let's say, a sister who developed breast cancer.
Sure.
And now they have come to menopause. What happens now? What do I do?
Right.
Because my sister had breast cancer.
Right.
Well, the National Institutes of Health has rewarded us with a proper, prospective, randomized study comparing the sisters. It's called the Two Sisters study.
Huh.
And that was completed 2 years ago. It only was published in the last year and a half. And its first author is O'Brien. And what she shows very clearly is the sister of the woman who'd had breast cancer, if she received estrogen versus not getting it, has a markedly reduced risk for developing breast cancer herself.
Wow.
So what it's getting at is the story of estrogen and breast cancer is complex.
Correct.
There are actions that'll make breast cancer cells grow.
Right.
But there are also breast cancer cells, when they are faced with estrogen, the estrogen will kill the breast cancer
You know,
cell.
it's interesting you should bring that up, because I remember many, many years ago during my training in the 1970s, and back then we didn't have the aromatase inhibitors, and tamoxifen was just barely coming out. And we used to do adrenalectomies, and we were taking the ovaries out and taking the adrenal glands out. And as women progress their disease, often paradoxically, they're actually given estrogen, which then put them into a time period of remission. So it is a very, very complicated subject. In the same vein, one of the points you made to me that I thought was absolutely fascinating was the whole conversation about vaginal dryness, and that actually if you use topical estrogen to build up the thickness of the lining of the vagina, that once you did that, the actual absorption of estrogen was markedly decreased, so that women who were actually using vaginal estrogen had less to worry about. Do you want to elaborate on that a little bit?
Well, there is a group called the North American Menopause Society.
Okay.
It has a website, and it has a website for women to get information and also to know where the certified menopause providers are in the country, because they're not easy to find. But there are now a growing number. We have just put together a new position statement, which is right on with what you've just said. And it is making the statement that the vaginal tablet or local vaginal estrogen is safe to use for women who are being treated for breast cancer.
Right.
And they need not have to put up with dryness, with urinary problems, with frequency and leaking, with pain with intercourse. Right. That the estrogen main role for those women is actually, as you said a moment ago, to restore the cells that line the vagina, but also to increase the blood flow.
Sure.
I've actually published several papers of my own. The first was in 1977, measuring vaginal blood flow and the effect of estrogen.
Right.
It does turn out also, if a woman has had a hysterectomy, there's a marked decline in vaginal blood flow.
Yeah, well, that makes sense, because you think about some of the collateral vessels that are now,
Exactly.
disconnected and gone, so there would be less. Well, yeah, that makes sense.
So that's
sure.
a study that we did.
Wow.
We had the women come back at 6 weeks and 6 months, and we had done their vaginal blood flows before they had their hysterectomies.
Wow.
And that was published not that long ago in the
Okay.
Journal for Fertility and Sterility. So those women then, with that, any area of the body that has a decrease in blood flow is vulnerable. It's vulnerable to infection. It's vulnerable to
Sure.
death of tissue.
Sure.
Even if it's the heart, it's vulnerable to
Sure.
infarction. But in the vagina, if you don't have adequate blood flow, then in fact, the pH of the vagina changes. You wind up having yeast infections all the time, or bacterial infections,
Got it.
all of which can be avoided. So women being treated for breast cancer should not have to put up with that at all.
Now, that makes me think when we go back to the role of AHA, not only are we trying with this video to educate family members, consumers, women about the importance of estrogen, we need to be educating physicians, particularly medical oncologists, breast surgeons like myself. The information you're sharing with me today is vitally important to the providers. Is that part of the role of AHA as well?
Well, it is. And again, what you've just said triggered one of the papers that I wanted to mention today, which was
Okay.
only published 2 months ago.
Okay.
And I like the fact that the senior author of the paper is a man named Hugh Taylor, who is the chairman of the OBGYN department at Yale.
Oh, wow.
So I can promote Yale.
Sure.
But Dr. Taylor's study is a study of the role of knowledge of the data about estrogen and progesterone, and whether or not a physician prescribes hormone replacement. So what the study did was to give an exam to doctors all over the country based on the published findings. And the doctors could either get the answer right or get it wrong.
Right.
Well, it did turn out, and that's the core of this paper, it did turn out that the better your score, the more often you prescribed hormone replacement, because now you were up to date.
Yep.
It made a huge difference.
Right.
Now, at the same time, another paper I wanted to mention was published by Dr. Manson of the Harvard group and Dr. Kaunitz, who's the chairman in Fort Lauderdale. Dr. Kaunitz is also a member of our AHA board.
Yep.
He's the chairman in Jacksonville. And their paper is in the New England Journal of Medicine last year. And it's called A Perspective, and it makes the point. There's been a lot of rethinking about the role of estrogen for the treatment of symptoms and the prevention of disease.
Wow.
And I would add to that, extending life. We see all three are affected by estrogen.
Right.
But they make the point we have a major problem in this country. And that is if we raise awareness of the issues, we don't have doctors trained.
Yep.
And so we have a challenge. And that's one of the goals for AHA has been to have our professors speaking to doctors. While I'm here in this area, I'll be giving grand rounds at one of the hospitals. I'll be doing a seminar at another one of the universities. But there are more of me around the country who have been doing the same kind of
Outstanding.
outreach to bring the information.
Outstanding, Phil.
Yes.
Absolutely.